what's unstable angina?
Happens whenever.
Yeah, kind of. It can happen like chronic stable, but it can also happen unexpectedly. This vasospastic one, I learned it as Pring's metal, but it has that different mechanism of action. It's not just a narrowed vessel. You actually are having vasospasms that cause chest pain. And I saw a guy once, he had 15 bypasses because of this vasospastic angina. I was just like, poor guy. He was young too, like 38 or something.
Oh, wow.
Ooh, that's a horrible one. So this is sort of the overview. I must have taken something from somewhere that wasn't well focused. But, so I would kind of look at, okay, what do I need to know? Okay, we've got vasodilators, which are usually in the nitrate class. We've got calcium channel blockers, which have a characteristic of vasodilating. Then we have stuff that affects the heart rhythm muscle itself. We've got beta blockers, and we've got calcium channel blockers. This one has this dual role here. And then there's other drugs, right, which we get to. But I like this because it really helps me picture what I should study. So this is like a typical question. Your Joe Schmo is out mowing his lawn on a hot Saturday afternoon. He begins to notice chest pain. What should his first action be?
It's A. You got to take the tablet first, wait 5 minutes, and then if it's not gone, take another one.
Do we
and call
just stop what we're
911.
doing and sit to see if it goes away? Do we go ahead? I mean, it's a little bit of a, they want you to know what the book says and what you should teach patients to do. So the book says at the first sign of chest pain, they should stop all activity and sit down. Part of it is so that if you take nitroglycerin and vasodilate, and if you're standing up, what might happen? Could have a syncopal episode, right? Shoo! So stop all activity, then take your nitro. I've thrown in some keys on my slides lately just to kind of make it super obvious. It's not the only thing you should know, but if you know anything, you should know those things. So there's the same thing here that we had on that blurry slide. Nitrates, nitrites, beta blockers, and calcium channel blockers. So if you get asked, what are the objectives of taking anti-anginal drugs? What they're talking is, what are the objectives for the patient, not what are the objectives for the medicines that we choose. You're not prescribing. What you're doing is educating on what the prescriber has ordered. So we are talking about function. We want to minimize the attacks. We want to improve their capacity and delay them having the worst outcome. Well, I think the worst outcome is death, but
I mean, sometimes MI leads to that, so.
you know, MI is not so fun either. So knowing those objectives, super important. Patient with extremely high blood pressures in the ED, the provider will order therapy with nitro to manage the patient's blood pressure. Which form of nitroglycerin is most appropriate?
Sublethal.
So he's in the ED. He has an extremely high blood pressure.
IV.
So what do you think is going to happen in the ED?
They're going to give them IV. I give everything IV
Yeah.
in the ED.
Basically, if they're in the ED, everything is IV. By the
The
time you get
fastest
back
route.
there, or I mean, you're the nurse, sorry. By the time I get back there, you as the nurse have already started the IV, gotten the vital signs, are ready to implement the protocol as soon as the provider says go. So definitely it's the IV infusion because it has the fastest effect. That's why it's chosen. Sublingual is easier, but IV is faster. So yeah, this is a bit of a thinking question because we think of the sublingual nitro as being like the first choice, and here we were just talking about isosorbide versus nitroglycerin, and
That's if you're not in the IV with,
right,
or in the
that's
ED with an IV.
that's if you're in the community. Remember, the hospital's like a whole different magic world that none of us understand. All right, so knowing about nitroglycerin, it comes in a boatload of formulations, right? And these ones that have the little red star are the ones that bypass the first pass effect. Why did they bypass the first pass effect?
Because it's not going through.
Not to go. Yeah, it's not going.
Right, not going through the stomach, through the mesenteric artery, through the liver, right. All right, so there's a ton of ways. Nobody has any excuse not to be able to take nitroglycerin. Where there's a will, there's a way. So nitroglycerin actually has both a rapid and a long-acting form, as does isosorbide dinitrate, but isosorbide mononitrate is mostly a long-acting. So you get a little confused, but for the most part, I would choose to remember this as the rapid acting and this as the maintenance, these two. I don't think that they're gonna try and trick you, as far as I know. Don't quote me on that. Oh, I was gonna turn on that microphone, but I never did. I was gonna start recording. Oops. Well, Rita's recording if you need to hear me. So we already said mechanism of action was vasodilation, so we relax the smooth muscles all around the coronary arteries, but also elsewhere. And that was a take-home message from our. So the other one was the headaches. Headaches are expected. What did we say way back in the analgesic chapter about like why headaches happen?
All blood to the heart and
So we said that it happens because of vasodilation, and a lot of the meds we use for headaches are vasoconstrictors, right? That's why they were contraindicated in patients with coronary artery disease and high blood pressure and stuff. So this makes sense that if we're using a vasodilator, we might just vasodilate ourselves into a headache. And so the teaching is just, if you get a headache, this is normal and to be expected. Treat it with Tylenol. These are all the things. Postural hypotension, we already said that from vasodilation. This reflex tachycardia, so I put the explanation. So if you vasodilate and your blood pressure decreases, what does your heart do to compensate? Revs it up, speeds up, because you still need the same amount of oxygen, right? So it just speeds up. So you might get a drop in your blood pressure with reflex tachycardia. So if you ever see a clinical scenario where nitroglycerin was given and the patient is hypotensive and tachycardic, you may have some insight into why. This is common, skin irritation. Well, I mean, it does happen. I wouldn't say super common, but it does happen. And what do you teach patients in order to, if this happens? Yeah, what do you do if you have a skin irritation where you're putting your nitroglycerin on? Put it somewhere else. You rotate the sites. Generally speaking, unless it's an obvious, you have a contact dermatitis and your lips swell up or your arm swells up or something. But usually we just rotate. Then we talked. The next gen also had the tolerance. So this happens with both patches and with the oral, long-acting forms of nitrates, like isosorbide. So what you can do is teach about the topical forms, the patch forms, about taking that nitrate break. It's sort of like lidocaine, where lidocaine had, what was the rule for lidocaine patch application?
12 on, 12 off.
12 on, 12 off, right? Well, nitroglycerin is, on during the day, off at night, generally speaking, or on for 18 hours. 18? 6, 12. 16 hours, I can't do my math. Because, they can do it whenever they want. But teaching around that. Obviously, if they're on an oral, long-acting nitrate, and they're having symptoms of tolerance, they need to see their provider. Then their provider can tell them whether or not they need to take some sort of a nitrate break, because that sometimes happens. Yep, so that's what you're going to teach. These all make sense because the mechanism of action. We don't want to vasodilate on an already hypotensive patient. He needs some perfusion to his brain and kidneys, so let's not kill him. This one, if we vasodilate, we already have reflex tachycardia, and someone who's anemic doesn't have enough red blood cells to carry oxygen around. So often people who are severely anemic are already tachycardic. their body is speeding up what red blood cells it has around to carry oxygen. So you add hypotension onto it from vasodilation, and you may just give them a heart attack from demand. Closed angle glaucoma, so anything that dilates is going to increase the pressure in your eye. Obviously, we don't want to increase the pressure in your head if you've had a head injury. This one is a biggie. And so we haven't talked about these drugs yet. But erectile dysfunction drugs are vasodilators. That's the mechanism of action to achieve an erection. So Viagra, Cialis, Levitra, all of these ones you should recognize by the ending -phil. And you need to recognize it because they will not prescribe one if you're on the other. So if you're on a vasodilator, that's an erectile dysfunction drug, they won't prescribe you a nitroglycerin or a long-acting nitrate because of the potential of profound hypotension. Conversely, if you're on a long-acting, like an isosorbide vasodilator, they will not prescribe an erectile dysfunction drug that uses vasodilation. So there's questions like, if you're the nurse reviewing discharge meds and you see, isosorbide and sildenafil, what's your next step? Maybe they'll just give you a list of meds and you have to recognize, okay, he's got a long-acting vasodilating nitrate and they've also prescribed an erectile dysfunction vasodilator. This is a contraindication. I need to alert somebody. So it's unfortunate. The nurse is obtaining a history on a patient presenting with chest pain. What drug class would require the nurse to inform the provider before beginning the prescribed nitroglycerin?
Maybe B.
I think we just said it, right? So this is the class of drug that those erectile dysfunction meds fall into. Phosphodiesterase inhibitors. It's actually a PDE5. I should have put a 5 in there. And so if you see this class, or if you see the afil, sildenafil, tadalafil, recognize what they are, and that's the contraindication. Yeah. All the other ones can be safely taken. A patient with a known history of angina was walking his dog and developed chest pain. The patient immediately stops walking and sits down. All right, he did the right thing. He continues to experience chest pain when sitting down. When should he call 911? So not right now, not immediately?
No, you need to take one tablet. If it doesn't work right 5 minutes, then take
This is they want you to
then take
know
it.
what's the correct thing to teach patients, right? So you've already told them to stop what they're doing and sit down. He did it. Now he should take his nitro. If he's still having chest pain, somebody should call 911 and he should take the second one. And so I already put it on here, but you should know that the maximum in general is 3 tablets. The caveat is anginal pain that doesn't respond to nitroglycerin might mean they're in the middle of a heart attack. And a little bit of nitroglycerin is not going to turn that around. So that's why we call 911. Patients hate it. Don't call, it's just fine, I'm fine, this happens all the time. Well, all right, so nitroglycerin is the most important drug to treat angina. The IV form is used for blood pressure control in the perioperative setting. Lots of other reasons, but they're all just related to vasodilation. So I think we've said vasodilation about 43 times now in the past 5 minutes. So if you don't remember that, the whippings will begin. What do we need to teach? So don't chew or swallow. The nitroglycerin sublingual does have a little bit of a burny, I've been told. And so what that means to them is it's still potent. It does need to be kept, it's in its original dark glass bottle. It comes in that amber colored bottle. They should keep the metal cap on it, and once it's opened, they should take the cotton filler out. Once it's opened, it's lost its potency in 3 months, and so they should discard it and get a new one. What we find happening is that people use it until it's low, and then they get a new bottle and dump it all in, and now you've got mixed tablets in there, and not only do you not know which are the new and which are the old, but the old ones could be a year old and have significantly lost their effectiveness. So it's hard to get people to throw away meds when they're still in the bottle. I typically tell people, when you open the bottle, write the date on it. Just get out your ballpoint, your Sharpie pen, and write the date. In 3 months, you should throw that away and get another refill. So keep it in the original bottle. What if somebody's traveling and they say, I don't want to carry this bottle. Can I just put a couple in a Ziploc baggie? No. It really is affected by the exposure to air and starts to degrade. Then we talk about applying ointments and patches and rotating sites and allowing for the nitrate-free period. Those are the key points on what you should know to teach Joe Schmo. The IV nitroglycerin, this is the key one. It has to be given in this special non-PVC tubing and bag. Otherwise, it gets discolored. There's a chemical reaction that occurs. So if you happen to find any solution that's discolored, you throw it away. We said isosorbide. It's more of the controller. It is available in a rapid-acting sublingual or buccal, but we're not going to really focus on that. We'll focus more on the long-acting. That's what you teach them. So that's all of the vasodilators. Easy peasy, right? You got isosorbide and you got nitroglycerin. Yeah. And then you have the caveats about the IV tubing and what you need to teach them. Pretty straightforward. So then we go to the beta-adrenergic blockers. And as we've seen them before, they're in the drug class for hypertension. Now we can see it's in the class for angina. It's in the class for dysrhythmia. It's given after an MI because of its interference with damaging catecholamines. So that's the mechanism of action. You should review what's going on. We all are very familiar now with beta, with all of the adrenergic receptors. So the beta-1 receptors, here's what happens. And then when we get beta-1 receptors on the heart, when we block them, we get decreased heart rate zoning, decreased myocardial. Okay. Yeah. So if we decrease the demand of the workload of the heart, we decrease the need for extra oxygen. This looks kind of crazy, and it says SARS-CoV-2, but ignore that. Another key point is that we give beta blockers to everyone after they've had an MI because they have a high level of catecholamines. I'm standing over here because this is the sympathetic nervous system. What did we say catecholamines were?
Adrenal glands.
Yeah, adrenergic neurotransmitters. And there are other ones besides those, but there is a high level of circulating catecholamines, and what we find is that systemically has a really bad effect, especially on the heart, can lead to arrhythmias, can lead to cardiomyopathy, which we don't want. We don't want the muscle to get thicker. We like big fat muscles everywhere except the heart. The heart, we want a thin-walled, flexible muscle. And so that's the key. We always give beta blockers after a heart attack. So know your cardioselective beta blockers. That would be helpful. The ones that we use for angina typically are here: atenolol, metoprolol, propranolol. And I threw in Nadolol because I saw it once as a drug on the Hesse, I think it was. But these are the biggies. Too bad it's not Christmas time. That would have been great. So atenolol and metoprolol, as you've seen from our professional acted videos and our worksheet, that they are cardioselective beta-1 blockers given for prophylactic treatment of angina. They're given after an MI because it's been shown statistically to reduce mortality. So what's the difference between morbidity and mortality?
Mortality, how many deaths?
Yeah. And what's morbidity?
How many meeting disease?
It's like how sick you are.
Yeah.
You know. And so it reduces mortality. Now that doesn't tell us how sick they are, but they're still alive. And IV metoprolol is common to be the first thing given to a hospitalized patient after an MI. So you may be the nurse who's administering that. And so now you'll know why, and it's related to the catecholamines. These are all the other indications that we may have talked about. So migraine prevention, beta blockers are used for that. There's a condition called benign essential tremor where it's not a Parkinsonian tremor and it's not from any other cause that can be identified, but some people just have this low frequency tremor. So oftentimes we use a beta blocker to treat that. Hyperthyroidism, why would that make sense?
Because they heart beating
What's-
very rapid.
What's the thyroid's function in the human body?
It's metabolism.
Yeah, it's metabolism. It's like the control center for the speed at which everything gets done. So if you're hyperthyroid, you're telling your heart and other things to speed up. So you're going to be tachycardic if you're hyperthyroid. So it makes sense that we'd use a beta blocker to slow that down. And then there are some interesting, I won't say off-label because it's not off-label anymore, but it did start out as being off-label. So for people who have situational anxiety like stage fright, public speaking, or just taking tests, they found that just taking a dose of propranolol right before it kind of calms things down so that you can function your best. And it's pretty effective. Try it out before the public speaking.
Before exams, does it work before exams?
Before the exam, yeah.
Take like the
There
day
are
before.
people who use it
And
before
then
exams.
you can tell it's helpful or not.
You can tell for the person.
You mean 30, 40 minutes ago?
If you have anxiety and you have those palpitations and the feeling of anxiety in your gut, and you take propranolol, you will notice the difference. Your heart rate is slowed down. You feel a little bit more in control.
My question was.
We need that.
Yeah, I'll just hand them out like M&Ms.
Yeah.
Please do.
Before the
Yeah.
sound, like, you bring
Propranolol, propranolol.
Panhandler.
What if we have the first use syndrome and we're all passed out?
Everybody has some sort of like bradycardic syncopal episode. What happened to the class? Oh, I don't know. All right, so what they do want you to know is this contraindication. So people who have pretty significant asthma, remember that the beta 2 gets hit. Even in cardio-selective beta blockers, the beta 2 can also be blocked. And so we actually want that vasodilated, bronchodilated if we have some sort of asthma or COPD. But if we're taking a beta blocker that's for our heart condition, we may start to bronchoconstrict. And so they put this out there, and it's consistently through the book that this is a contraindication. Go ahead and learn it because you'll see it. But in clinical practice, I still prescribe beta blockers to people who have lung disease because they'll die without their beta blocker. So learn that's the contraindication. Then this is the other one we already talked about, can mask hypoglycemia, induce tachycardia, and then it's contraindicated if you have peripheral vascular disease. So we talked about this peripheral vascular disease, right? Where your blood flow in your extremities is compromised because you've got cholesterol buildup and plaques and atherosclerosis. So you don't want any vasoconstricting there. Generally speaking, if you've got a bad case of vascular disease, there's some people who can only walk, to the doorway before they have pain because of vascular disease, lack of blood flow, lack of oxygen. So we probably would try not to give them a beta blocker. What do we need to teach patients? So this is where you need to know what the parameters are that you teach them. You don't just say, monitor your heart rate and report any outliers to, you got to say, if your heart rate's less than 60 or significantly less than 60 or over, it's not going to usually be over with a beta blocker. So I guess we're talking about the low. You need to give them the exact number that they should be looking for, right? And that was a problem on our case study, was that it was like, oh, monitor your heart rate, but okay, I'm monitoring, but what do I do with that information, all right? What happens if you stop the medicine abruptly?
We have rebound hypertension.
Rebound hypertension and rebound tachycardia. And that probably doesn't feel really great. And then we also teach them, so you're doing your discharge teaching and they say, so when will I be able to stop taking metoprolol?
It's a long time.
What do you get to be the one that gets to tell them?
Oh, messed up.
Doctor.
Yeah, you get to say, we expect that this will be a lifetime medication, but that's something that you can, talk with your prescriber more about. It's unfortunate that we get that on our shoulders, because sometimes they can get off. If it's a younger person who had a heart attack and they gave a beta blocker afterwards and they've been on it for 6 months and they feel like crap on it, some people get off, but most people stay on. A patient who had a heart attack is taking a beta blocker. What's the main benefit of beta blocker therapy for this patient? So if it's a cardioselective beta blocker, blocking beta 1 receptors,
Slow heart rate.
right? So slowing the heart rate allows time for the ventricles to fill so that you can get more volume per squeeze. It does, and that if you don't have to squeeze so many times, if you can slow it down so we can fill and get a big push, that actually is reducing the demand for oxygen. So it's a great thing. And also the irritating effects of catecholamines, which wasn't one of the options up there. All right, beta blockers now. Easy peasy. Yep. Calcium channel blockers. So we use calcium channel blockers. Remember we said it had a vasodilating property as well as a heart function. So there are 2 categories, and if they have long fancy names, and it's just the way it is. The way you learn them is like this. Dihydropyridines start with di, so their function is dilation. Dihydropyridines dilate. And so all the drugs in the dihydropine class end in INE. So amlodipine. All those enes fall into this class. There's only 2 big ones in the non-dihydropyramine class, and they're verapamil and diltiazem, and they're used more for these dysrhythmias than they are for angina. We tend to use the ones that are better at dilating.
Is that one a benzo? No, not a benzo.
No, these are all calcium channel blockers.
Oh.
So there are 2 categories of calcium channel blockers. All calcium channel blockers fall into 2 classes. Dihydropyridines, which act by dilation, and non-dihydropyridines, which act
Sorry,
on the
it was
conduction system.
The name threw me off.
Yeah.
It looked like
No.
diazepam.
Not related to diazepam. Here
No.
it is in visual form.
Thank you.
Dihydropyridine. Di means it does what?
Dilate.
Dilate. The medications end in INE, amlodipine, nicardipine, nifedipine. Makes it pretty easy to remember. The non-dihydropyridines we'll talk about more in the dysrhythmics, but no, that's verapamil and diltiazem. They're kind of their own little funky babies. So when do we use a calcium channel blocker? Well, it's not our first choice for hypertension, but we might use it in certain populations. We use it for angina, we use it for this Prinzmetal angina, the spastic one, when nitrates or beta blockers fail or are not suitable. So we also use it for dysrhythmia. Sometimes it's a twofer. And then we use it for short-term management of atrial fibrillation and atrial flutter. What's the difference between fibrillation and flutter? It's just the speed at which the heart rate is going. Right, fibrillation is going to be somewhere in the 140 to 180 range, and flutter is going to be anything over that. And it's a really deadly, like flutter. You can go into some ventricular dysrhythmias and die. So flutter's a big deal. Fibrillation's a big deal because it makes clots, but flutter is more deadly. All right, amlodipine ends in ene, so we know what category it falls into and how it acts. For angina and hypertension, available only for oral use. So the side effects are primarily related to overexpression of their therapeutic effect of vasodilation. So where do people usually experience the overexpression of the therapeutic effect of vasodilation as a side effect? Where does that show up physically on their body? It's a side effect of the drug that's caused from vasodilation.
Headache?
Not headache, but good guess. Where does gravity pull?
Orthostatic hypotension.
So we end up with lots of swelling in the lower legs. And I've seen people take a low dose of amlodipine and literally calves this big from vasodilation. And then when it vasodilates, you get a lot of capillary leakage and lymphatic leakage, and fluid just stays there. So if it's not that bad, but you need to be telling them, okay, when you start amlodipine, you might notice that your feet and ankles or your lower legs, your calves start to swell. That's not necessarily heart failure, because we usually think of that as being a heart failure sign. It's more likely related to starting a calcium channel blocker. And amlodipine is the classic one that does this. So sometimes it can be managed by wearing compression socks, just like the ones you can buy in the grocery store, or there's a seat over here, there's a seat over there. Oh, we've got a few seats everywhere for you. So that's a teaching point of what to expect and then how to manage it. Obviously, if they're super concerned, you'll want to, especially if they're leaving after a hospitalization for something, we educate them, but then we also let them know they can contact their provider. Because what if they are having a heart failure exacerbation? Are you going to know that? No. I mean, labs are going to tell that and a physical exam. But otherwise, somebody who's in the doctor's office and just started on it, now you know. So this is the non-dihydropyridine, this diltiazem. We say it's very effective for angina from coronary insufficiency, just meaning the same thing, atherosclerosis and hypertension. We do use it more for AFib and A-flutter, so it's more in the rhythm category. But recognize it's a calcium channel blocker. So all of the adverse effects, here they are. Headache is one, good job. This peripheral edema, that's what we're talking about, swelling in your feet, ankles, or lower legs, can be anywhere there. Dizziness is related to the hypotension. Palpitation usually happens because you vasodilated and your blood pressure dropped. Tachycardia, same thing. Now, bradycardia can be because of the conduction properties of the drug. It's interfering with the flow of electricity between the SA and the AV node, so you may actually end up with some bradycardia. So if somebody has a pulse of 46 and they're symptomatic, you want to make sure their prescriber knows. And then what should we teach them? In this category of, constipation is a common problem with the non-dihydropyridine, so that's the diltiazem. Let's go back. These ones tend to have problems with constipation as a side effect. These ones tend to have problems with vasodilation as the side effect. So I didn't make that very clear on that slide, sorry. So those are your side effects and then contraindicated. So you don't have to know all the types of heart block. Just know that heart block is an issue with the electrical conduction system of the heart. And basically there's a wiring issue where the circuits are going haywire. And so we don't necessarily want a patient to take something that suppresses electrical activity in something that's already gone haywire. So if they have some type of heart block, if you see that on their diagnosis sheet, that might be a little red flag. Like, I remember something about not giving calcium channel blockers to people with heart block. So that's a good thing to remember. There is this other miscellaneous anti-anginal, and I've seen them before. This is ranolazine. We don't actually know how it works, which is awesome. You don't have to memorize the mechanism of action. It is a great drug. It does its job. They only prescribe this if the other ones have failed and people still have angina, even on maximum medical therapy. Some people can't take maximum medical therapy because they have so much vasodilation, they have no blood pressure. And so ranolazine works great. The problem is it can prolong the QT interval. So I think I have a slide. No. Later on, I have a slide about the QT interval. We'll talk about it. And so, yeah, reserved for those who have failed everything else. We will go over this QT prolongation and what it means, and if they're taking other drugs that prolong the QT interval, and then if there are any drug interactions. The nurse is preparing to educate a group of patients on the management of angina. Which 3 drug groups are most often used to treat patients with angina? What are the 3? Well, what's the class?
Nitrates.
Nitrates, vasodilators, beta blockers, and calcium channel blockers. Easy peasy, right?
Right after you tell us.
Yeah, you got it.
It's like say that in two
A plus. Nitrates, beta blockers, calcium channel blockers, right? Patient asks the nurse to tell her more about a new drug the patient has been prescribed called ranolazine. Which response by the nurse is accurate? This one's probably, you'll figure it out by process of elimination. Yeah. Say, you can rule out everything else. Because we don't know how it acts, we do know that it doesn't reduce blood pressure and it doesn't reduce heart rate. Otherwise, we'd say that was the mechanism of action. We don't know why it works, it just does. It's not the first-line treatment. We've already said that. It is an oral medication, and it's contraindicated in patients with liver failure. So there was a lot in that slide that they were asking you to know. What information will the nurse include when teaching the patients about taking beta-2 blocking drugs? Beta-2 blocking drugs for the treatment of angina. That probably should have said beta-1. Or non-selective, or I don't think beta-2 is correct. I don't think we're going to take albuterol for angina.
I thought beta 2 was for your lungs.
it's a
for
typo.
pulmonary.
Ignore the man behind the curtain. What should we tell the patient about taking beta-1 blocking drugs for the treatment of angina? Yeah. So obviously, we're talking about the risk of somebody having a condition where their heart failure is either begun or worsened. And that's not to be confused with the side effect of lower extremity edema. So we really want to be telling them the parameters of what they should be watching, not just weigh yourself every day at the same time and keep a log. But, hey, if you gain 2 pounds in a day or 5 pounds in a week, it's a big deal. You know, don't just say, oh, it's because I ate a big meal at Cafe Rio or something. No, you need to call somebody, because usually the nurse on the phone is going to be asking, so have you noticed, are you coughing more than usual? Are you more short of breath than usual? You know, all of the symptoms that are more subtle for a heart failure exacerbation. And then, of course, this one was wrong because we've already said that they want you to generally consider them not recommended. Patient asks how to apply transdermal nitroglycerin. What's the nurse's best response? And I guess I should have said patch. Apply transdermal nitroglycerin patch.
C.
What, you don't want to put Vaseline on first? That doesn't make any sense. Yeah. So obviously it's hard for hairy men, but try and apply it to a hairless area of the body, rotating it. Make sure that you're educating to take the old one off. Don't be leaving, somebody that looks like a target practice with patches all over their body. And obviously we don't put petroleum jelly because nothing would stick. All right, anti-anginals, you know it all.
Yay.
Take a quick break.
We're ready for the
You're